Hello and welcome to everybody for our talk this afternoon about ME and chronic fatigue syndrome in children and young people, and we're delighted to have two eminent guests with us this afternoon to share their knowledge and expertise. We are both doing this talk on Zoom. We had about 80 or more people signed up to the Zoom chat, so we're delighted that everybody's shown so much interest, and obviously people will be joining us on Facebook too. We'll be using the chat function, so we'd be delighted if anybody wants to pose any questions to either of our speakers, and I will then put those questions to them at the end of their talks. So if you've got any queries or anything that you'd like me to ask on your behalf, then please put them in the chat room or on the Facebook page, and we'll pick those up. I'm very grateful. I'm being supported this afternoon by Eliane, who works for the Sheffield ME and Fibromyalgia group. Do you want to say hi?
It's muted.
Hello.
There we go. That's Eliane. She said hi. So we're grateful for her technical expertise in this. So interested to know where everybody is from. If you'd like to post in either of the chat room or on Facebook Live where you're watching or listening from, we'd be very intrigued to know. Obviously our group is based in Sheffield. We cover South Yorkshire and North Derbyshire in the UK, but we frequently get visitors from right across the world coming to these talks, so we're keen to know where you're from. Very briefly, the Sheffield ME and Fibromyalgia group is a very small charity. We cover South Yorkshire and North Derbyshire, and we cover both ME and fibromyalgia, and we do our very best to support and reduce social isolation for adults and for carers and families. We've got an amazing Oktoberfest of all sorts of fun activities coming up, so please visit our website, www.sheffieldmegroup.co.uk, and it's particularly designed to be friendly to people with ME and their carers and people with fibromyalgia. We also, of course, as a small charity, rely on membership. So if anybody particularly is here from the area and you're not already a member, then please join us. If you go to our website, you'll find out how to join there. So we are recording this, so that's why we're not sort of showing everybody else's faces, and so all you'll be seeing is either myself or Dr. Nigel Speight or Debbie Burgess. But we plan to do a first initial talk by Dr. Nigel Speight for maybe about 40 minutes. Then we'll process some questions, and then Debbie Burgess from the TYMES Trust is going to talk about the work of the TYMES Trust, and there'll be opportunity for more questions for both Debbie and for both of our main speakers that we can use at the end of the session. So I would like to move on to introduce our first speaker, Dr. Nigel Speight. Nigel is described as semi-retired, which all the people I know who are semi-retired means you're kind of not really retired at all. You're just perhaps not being paid as much as you did when you were in employment, but probably working incredibly hard. Nigel's a specialist in pediatric ME chronic fatigue syndrome, and has particularly during his professional life been involved in fighting many child protection cases, and is seriously concerned about children and young people with ME and chronic fatigue syndrome who sometimes are misdiagnosed as having psychiatric conditions and run the risk of being taken away from their parents or carers or from their homes. Dr. Speight acts as an advisor to a number of ME charities, and sometimes his outspokenness about how young people with ME are treated has given him a slightly rocky ride. He is one of the authors of the 2017 Pediatric Primer, and I'm going to start by asking Dr. Speight to talk through what is the body of knowledge at the moment about the condition of ME, or the conditions, since we don't know it's one thing, and how that relates to children and young people. So,
Right.
Dr. Speight, can we invite you to...
Thanks for inviting me. It's a pleasure to be here. It's very unnatural not being able to talk to the audience. I'm always remember speaking to an audience of parents with children with ME and looking down from the platform and seeing little white faces scattered around the sunburned parents. And it's the white face of ME is absolutely classical, as you know. I'll say a bit about myself before I try to answer your question and talk about what I'm trying to cover. I'm going to tell a bit about how I got interested in ME in the early years and how and what it led to. I'm then going to discuss and dissect the psychosocial model and give you ways of arguing against it. I'm then going to talk about the importance of diagnosis. Then I'm going to talk about important milestones of the last 20 years. And then sadly, I'm going to end up with saying why things seem to be getting worse for children. And I'll describe that. And then I'll interject lots of little anecdotes, try not to depress you too much, and try to end up with a joke to cheer you up. Is that okay?
Perfect, thank you.
The broad question about what do we know about ME in children as opposed to ME in adults, I think the answer is they are essentially the same condition with variations. The biggest variation is that the outlook for children with ME seems to be slightly more positive. They seem to have a higher chance of full recovery. And I certainly have had quite a lot of cases in my career who've had very severe ME who have made virtually full recoveries. And I have one of my favorite cases is a boy who actually climbed Snowdon, Scafell Pike and Ben Nevis in 24 hours and didn't suffer any consequences. So that's what I call full recovery. And he was wheelchair housebound for missed 2 years of school. So it's a bit more optimistic. It's similar to adults. No one should say you're too young to have ME. I've heard that many times. The youngest case I've had probably developed it with a viral infection at 18 months. So there's no lower limit to when you can develop ME. But the main peak, as we all know, is round about 11 to 15 teenagers. I think I'll stop on that question there and go on to my other things, if that's all right. But there'll be room for more questions later.
Okay, I did ask the audience about who is a parent and who is living with ME themselves. So we clearly have quite a number of parents here. So
okay.
Yeah.
And the other thing I forgot to say was just to express sympathy to all of you in the various ways in which you are suffering this very, very infuriating condition. I was appointed a consultant at the age of 40 after 16 years of medical practice. I did adult medicine, I did tropical medicine, worked in Africa, and I did pediatric training in Newcastle, and was appointed a consultant in Durham. And I had hardly even heard the word ME, let alone been taught something about it. But you can learn a lot after you become a consultant. The first time I virtually heard the name mentioned was at the consultant's dining room, where a respected lady physician colleague said to one of her fellow consultants that all her patients with ME were nutters. And I heard her with interest and thought that was a bit derogatory and maybe I would keep an open mind. Shortly after that, a girl came to my clinic in a wheelchair and announced that she had ME and her parents ran the local ME charity. And I said, tell me all about it. And she explained, said how she could sometimes get to school for 2 or 3 days, but if ever she did PE or went swimming, she'd be confined to bed for a week. And I was impressed. It struck me as a very genuine condition. And I then had the fortune to hear the late Betty Dowsett give a lecture to our postgraduate meeting. And she gave a brilliant exposition of how to diagnose ME, all its clinical features, the theories behind it. And I felt that was enough to be going on with. Then, because it turned out that I believe in ME, patients started gravitating to me from the whole of the northern region. So I decided to do a survey to try to find out how many my fellow pediatricians could share the load. And I just wanted to find out their basic belief systems. And this questionnaire I sent to them is a questionnaire you might all bear in mind. I'm sorry I don't have a PowerPoint with it on, but basically it's worth asking any doctor who's seeing your child the following questions. Which of these belief systems do you adhere to? And the position A is that ME is a basically physical organic disease that can affect anyone who is psychologically normal or abnormal. It can just affect anyone. It's basically a physical illness. And question B is the opposite, that ME doesn't really exist and it's purely psychological. And the third possibility is what I call the fence sitters hypothesis. Oh, it's all very complicated. It's a bit of both. And I was very heartened sending it to my colleagues in the northern region that 19 against 7 voted for a physical illness and the 7 voted for purely psychological. It's still alarming that those 7 voted that. But it struck me at that time, there were quite a lot of old school pediatricians who were used to making their own minds up, taking a careful history, learning on the job, and hadn't been affected by the defects of medical education, which we can talk about later. For interest, I sent the same questionnaire to the child psychiatrists in the northern region. Again, I wanted to know their views, because sometimes a child with ME can benefit from seeing a child psychiatrist on their own merits. And you won't believe it, not one child psychiatrist could bring themselves to tick any of those boxes. And instead they wrote me long essays on the reproaching me for even asking that question and reproaching me for not being aware of the mind-body continuum. And that is what I've always said, is kind of psychobabble, isn't it? At a later stage, I had the chance, I demanded the right of reply for a national pediatricians meeting, which had been addressed by a child psychiatrist of the opposite view the year before. And I managed to put across the organic hypothesis, and on a show of hands of British pediatricians at that time, over 50% voted for organic. Most of the others voted for position C, the fence sitters, and only one pediatrician in the whole audience voted for psychological. So at that stage, I thought we were flying the flag and keeping it going. I'd like to say something about the psychosocial model. They call it the biopsychosocial model, but if you notice, they always forget the bio. So it's just the psychosocial model. And this is that really ME doesn't exist, that it's a construct of people's minds, that basically it's due to abnormal illness beliefs. And then because they have these abnormal illness beliefs, they stay in bed and get weaker and weaker. In other words, they suffer from deconditioning. And the treatment from this logically is cognitive behavioral therapy, CBT, to help their abnormal illness beliefs, and graded exercise to get them fitter. Now, you and I all know that this is rubbish, but why is it rubbish? Firstly, the symptomatology of ME is very complex, and there are about 15 possible symptoms. And these patients all have this constellation of symptoms. It's not just tiredness, it's a complicated clinical history, it's a clear-cut clinical syndrome. And how can they explain that everyone in the world with ME comes up with this same combination of symptoms? They have to postulate a conspiracy theory worthy of Donald Trump's fake news. That just doesn't happen that way. So they've all got the same symptoms. It's a clear pattern. Secondly, if they were right, there would not be a controversy. Everyone would already have been very gratefully cured by CBT and graded exercise, and we'd all live happily ever after. And as we know, that doesn't happen. So the failings of CBT and graded exercise show that by their very nature that this hypothesis is completely incorrect. The proponents of the theory also fail to explain the severe cases. They don't find enough psychopathology in the severe cases, And if you notice, they avoid them like the plague, never visit them, and don't do any research on them. So again, CBT and graded exercise fail to cure the severe cases. And they also fail to explain the epidemics, which have been all over the world, and they can't say they're all due to mass hysteria. I finally think that the occurrence of ME in children is actually one of the most convincing, part of the most convincing evidence for its organic nature. Then if you see a kind of 11-year-old boy who's full of beans, loves football, goes to Cubs, does this, swims, is in the local swimming club, who's struck down by a virus on holiday in Greece, comes back and is absolutely knackered for 3 years, that is not someone who's suddenly developed abnormal illness beliefs and has got deconditioned. He's ill. And I was talking to a nice adult neurologist. As you know, neurologists hate being responsible for ME and like to not believe in it. But he was a very nice neurologist, and he was describing how if a patient complains of something that seems genuine, but that he can't quite explain it, he says he'll keep an open mind. So I said, oh yeah, what do you think about ME? He said, oh, I don't know, why do you ask? I said, oh, well, I see a lot of children with it. And he said, do children get ME? I said, oh, definitely. I've got 50 cases in the last few years. He said, gosh, maybe I should think again. And now that's a nice approach from a doctor who's willing to open his mind. And it shows that, like many doctors, he was used to the idea of my first colleague saying they're all adult nutters. It's all because they're unhappily married or can't stand the strain of their teaching jobs, and it's just a good cop-out. But if you see a kid struck down with ME, I find that convincing. And so many doctors these days seem to demand a test for a condition. The late Alan Franklin, who taught me a lot, used to say, we have reared a generation of doctors who depend on investigations rather than on good clinical practice, taking good histories. And I always remember a lovely TED talk by Abraham Burgess to Edinburgh medical students, where he said, we're rearing doctors in America who can't diagnose that a patient only has one leg without a full body CT scan and an orthopedic consult. That's a joke. So I say with children, if something looks like a duck, flies like a duck, quacks like a duck, and lays duck eggs, it's probably a duck, even if you can't get a blood test for it. So I need no convincing that hypothesis A is the truth. That children and severe cases are particularly convincing evidence of that. And if any of these arguments help you in trying to educate your local doctors, well and good. The great William Osler in 1906 described all the features. He knew about taking a good history. He was a great clinician, and he described all the features of ME beautifully in 1906. He unfortunately called it neurasthenia in those days, but he stressed it was genuine, it was physical, and these patients needed treatment with respect. So the history is important. The trouble with current medical education in this country, both undergraduate and postgraduate, is that it hardly ever includes ME. And unless you go to a clinic with a physician who's sympathetic, who sees ME patients, a doctor can get through his medical education never seeing a case. And I know some of my colleagues, especially Dr. Nina Muirhead, are working very well with medical schools, trying to get some part of the curriculum, because they're all responding differently. But I think if you could just show every medical student a case of a young child with ME with their mother talking about it, it would be useful. But if you have a medical curriculum that doesn't teach you about ME, then the inference for new doctors is that it doesn't exist. And this reminds me of a GP in Devon who saw a good friend of mine who has ME, and she announced to him that she had ME, and he got up from his seat, towered over her, and said the following memorable sentence: I can assure you, I have been a doctor for 12 years, and if such a condition existed, I would have heard of it. Therefore, it doesn't exist.
Does anybody keep a book of these quotes? We hear so many all the time. They're often appearing on our Facebook groups.
Trade secret, I'm writing a book.
Aha, aha, that's what we like to hear. Thank you.
And again, I was at a recent case conference and of a family accused of fabricating their children's illnesses. And the pediatrician there said, I am a scientific doctor and I cannot make a diagnosis if the tests are normal. It reminds me of a 6-year-old girl seeing a famous professor who actually said, but you can't have anything wrong with you because all your tests are normal. And the 6-year-old replied to the professor, perhaps I've got a condition for which you haven't yet invented the right test. I think that's game, set and match to the 6-year-old.
Absolutely perfect. You've sold your first copy of the book, by the way.
I'd better get writing it.
To Catherine from Ireland, who is raising concerns about how to persuade doctors to believe the condition. So yeah.
Have you seen the? I just got an old book of cartoons from AFME from many years ago, and it's got a beautiful one of a GP's surgery. And there's a rather harassed-looking GP sitting there, confronted by a kind of waiting room full of obvious ME patients, looking very droopy. And their spokesperson says, "We've heard a rumor that you were once nice to a patient with ME."
AFME being Action for ME. Anybody
Yeah.
doesn't know?
Just a quick word about terminology. I'm sure, like me, you all hate the term chronic fatigue syndrome. It was invented by the psychiatrists in the 1980s to try to debunk the reality of ME. ME is so much more powerful, isn't it? If you have a child who's off school for 2 years and then goes back and they say, oh, why have you been off school? Oh, I've had chronic fatigue syndrome. You skiver, kind of pull the other one. But said, I've had ME. Oh, gosh, I've heard about that. It can be quite nasty, can't it? It's much more powerful. I certainly found it more powerful writing to head teachers. The great advocate and Tanya Harrison said at the CMO's report, abolishing the term ME, which is what the psychiatrists want to do, and replacing it with chronic fatigue syndrome would be as unhelpful to the patient community as it would be to abolish the term Alzheimer's disease and replace it with chronic forgetfulness syndrome, because we all get a bit forgetful sometimes, don't we? And I'll give you one particular example of how this terminology lets patients down. I was seeing a 14-year-old boy in Scotland because his mother was being prosecuted for his non-school attendance. He was barn door, straightforward, severe ME, housebound. But his pediatrician had initially made a confident diagnosis of chronic fatigue syndrome. But the school weren't happy and he couldn't stand up to them. So he diluted it the next time he saw the patient to chronic fatigue, missing out the syndrome. And that's just a symptom, not a diagnosis. And the third time he actually put chronic fatigue, no organic cause found, and left the mother wide open to prosecution. And it's such a weak term that people who only use chronic fatigue syndrome won't call it ME. It's as if they don't really believe in it. They take the kind of position C.
There is a query about whether maybe at the end you could point people to any resources which would help professionals in their assessments.
Just coming to that. Coming to that.
Perfect. This was rehearsed many times, not.
Now, firstly, that I'm a strong believer in the pointing back to every GP, every pediatrician, every physician in the country, and putting the responsibility for diagnosing and supporting most cases of ME back on their shoulders, and getting away from this idea that specialist services 30 miles away are ever going to meet the needs. And so I say that basically the ability to make a diagnosis of ME and to manage the average case should be within the core competence of all those doctors. And the resources I would point them to are the CMOs in terms of diagnosis. The guidance for diagnosis in the following 3 publications are absolutely easy. They're in the CMO's 2002 report, the College of Pediatrics 2004 report guidelines, and even in NICE guidelines in 2007. Diagnosis, guides to diagnose it are there, and all you need is the ability to take a decent history, and of course have enough time to take a decent history. And I could teach a 10-year-old Boy Scout to diagnose ME in half an hour. I could teach him in half an hour, it would take him an hour. So you can always point them to those. You can point them back to the primer, the international consensus, and all these things. But basically, if you take a decent history of all the things wrong with someone, you end up with a provisional diagnosis of ME. So increasingly, I'm hearing doctors saying, I can't diagnose ME because I haven't been trained. These are consultant pediatricians. Said it should be part of your core competence. After the CMO's report, I thought things were going quite easy, very favorably. The CMO, if you remember, Sir Liam Donaldson, at the press conference said, ME is a genuine condition and patients should not be dismissed as malingerers. We all thought, hooray, we've won, we've won. But the psychiatrists keep making their comeback, and they go back with their CBT and their graded exercise and their research. And there's always this fight back. So the actual course of the controversy has been up and down ever since. I'll tell you one reason why things are actually getting worse in pediatrics. And again, 10 years ago, when I retired, I thought I could really retire and everything was going to be just fine. At one stage, I had about 7 or 8 pediatricians around the country who were supporting the charities like me and seeing difficult cases. And they've all either died and retired, and I haven't been able to recruit anyone else. Now, the reason things are getting worse, and this is real depressing, is because of a new growth industry in pediatrics. And this industry is massive, and it has thrived on the fact that workshops have been held all over the country for pediatricians, GPs, social workers, and teachers. And people go to these workshops and come away and they see what is the new term for Munchausen by proxy. Now, Munchausen by proxy, we all know, was real. It was as rare as hen's teeth. I've seen 2 genuine cases in my entire career. Really tricky parents who put nasty things into their children's milk bottles, salt, and then they put blood into their son's urine specimens and pretend they got kidney disease. Really, really tricky. And we know about that. But they changed the name to fabricated and induced illness. That would be okay. It's the same idea. But what's happened subsequently is some authors, who should be nameless, have spread a doctrine that there is a wider variation of fabricated and induced illness, where the umbrella is cast really wide and the number of possible cases has kind of increased, I would say, 100-fold. And I spoke to a pediatrician in one center who said that she had 130 families under surveillance for possible fabricated and induced illness. Now, the reason this has grown, apart from all these workshops, is that the definition, and there's a flow chart that comes with these lectures, the definition has widened to include 2 crucial new areas. One is medically unexplained symptoms, or MUS. The other is perplexing presentations, or PP. Now, if you have any of these, in other words, if the doctor has failed to explain 1 or 2 of your symptoms, then you can have a strategy meeting, and then you can offer the family, if the flow chart shows, you offer them rehabilitation through a multidisciplinary team, and if they decline it, you go straight to child protection. So that's why more than 100 families will be subject to this. And not just the PPs, the ones who don't have, who have doubts about their child's ME will be at the mercy of the industry. And basically, if any pediatrician fails to give their patient the full protection of a confident diagnosis of ME, their patients are sitting ducks, like the patient in Scotland was. The education pushed for prosecuting the mother because the pediatrician didn't defend them enough. So diagnosis is important for protection.
And the rehab services that are mentioned on the flow chart, that those rehab services would presumably include graded exercise or CPT or
well, it's aimed at, it's aimed not just at ME, it's aimed at anything that perplexes doctors.
Yes.
So you're actually offering them a rehabilitation service for something you don't understand.
Yes.
But if they're in pain, they get sent to a pain clinic, and they usually get sent to a psychologist, and then, you know, but it's mindless to rehabilitate someone when you don't understand it. But the assumption is always that if the doctor can't explain it, then unlike the professor in who the little 6-year-old girl says, well, maybe it's your fault you haven't explained it yet. So there's a kind of arrogance that if it's medically unexplained, the parents are to blame. And this affects a lot of other conditions apart from ME. It affects people with food allergy, Ehlers-Danlos syndrome, and especially autism. So there are charities to protect families for all these conditions. I had an example just this week. There's new cases coming every few weeks, and I've had 25 to 30 cases of ME children accused of FII in the last 5 years since this industry got going. And this week was a girl who, no, it's a boy, sorry, who had I had actually diagnosed with ME a year ago at the mother's request because they couldn't get a diagnosis out of the local pediatrician. And the pediatrician had referred her to the local CFS clinic. I tell you, this CFS clinic consists of a physiotherapist and a nurse. And so many of these specialist clinics don't actually have a doctor who can make a firm diagnosis. Because the physio pushed graded exercise and the child got worse and the mother withdrew him, they've now had a strategy meeting and she's accused of fabricated illness for declining graded exercise. So any form of declining something that the doctors think is good for you leads you into this flow chart of child protection. Those of you who read the Times may have heard about the case from Cumbria. That this is in the public domain. Lovely family, both teachers, and they had a son of 17 with ME, and he was definite, but he had 1 or 2 puzzling features, but he was quite severe. And then when their younger daughter developed probable mild ME but couldn't get a diagnosis, the named doctor for child protection elbowed the other doctors aside, took over both cases, and convened strategy meetings, and then went straight to social services. And the first this family heard about it was when they were invited to their case conference. And they were absolutely distraught, and it was exceedingly stressful for them to do it. And then a lesson from that case, and we're talking about people who are in trouble, is don't be afraid to go to your MP. That MP put pressure on social services. They weren't going to invite me to the case conference, and they had to, and we finally just won the case conference. Even worse, if I can depress you further, and this case is subject to court, and I can't say where it's from. A mother had a 5-year-old boy with probable ME and was being managed by a pediatrician at her local hospital, and everything seemed to be fine, but all the time, because the pediatrician had probably gone on a workshop, she was plotting. And the first that mother heard about it was when the police turned up with the pediatrician, with what mother said was a broad grin on her face, and the child was arrested and placed in foster care. And it's a horrible industry, I can tell you. And it's almost like, you know, the House on American Activities, searching out communism and deviationism everywhere. It really is a kind of witch hunt against innocent families. Say a bit about how we're doing. Oh, we're nearly finished.
Got
What to
a
do?
particular
What to do?
query about whether you've got any comments about some of the specialist units in hospitals.
I've already been rude about them. Oh, you mean actually inpatient units?
Yes. I mean, I don't know of many, so
I think I'd prefer to comment on those off the record.
fine.
Just a little bit of advice on what to do if you do get sucked into this machinery. Once you're referred to social services and you're trying to convert them and argue with them, actually don't waste time and effort arguing with social services. They're trained not to listen to you. Even at case conferences, I've heard eloquent parents winning their arguments, and it doesn't even get into the minutes. You need allies. You won't win the argument yourself. There's one exception to this, and that is when a family made the social worker see the film Voices from the Shadows, and it completely converted her, and she became a fervent advocate for the child in question. And so that's a form of getting allies. And the other thing to remember, if you are referred to social services by the medical profession, don't despair. Social services sometimes get it right when the doctors have got it wrong. And another argument you can use, because so often these FII, fabricated illness diagnoses, are generated by a strategy meeting with Uncle Tom Cobley and all, and it's a teacher and a nurse in child protection and a whole room full of people who've never even seen the family. FII is such a serious diagnosis, it's actually potentially a criminal offence, that it should only be made by a paediatrician who understands enough about medicine to exclude other things and to be firm. So don't let other people, amateurs, say, well, we think it's FII. It has to be a paediatrician. And a lot of cases I've seen, it's gone ahead without a paediatrician committing themselves. So shall I just finish with my funny story? There was once a guy who decided he wanted to cycle from Land's End to John O'Groats. So he thought he'd find a charity, and he actually supported one of the ME charities. I think it was Action for ME. And he said he didn't know much about ME, but he was very grateful because the charity put him up with families, ME families, all the way up to Scotland. And he met them all and chatted. And as he handed over his cheque for £10,000, he said, there's one thing I don't understand about this condition. He said, does it only affect nice families? Or can it affect anyone and then it turns them nice? And I think there's room for a research project there. There's a great truth in it, isn't it?
There is great truth in it. I've met such incredible humour as well amongst people and families living with people with ME. So yeah, a source of both niceness, gentleness, generosity, and very good humour. So fantastic. Thank you. That's an absolutely brilliant, very helpful run through of the whole field. We've had lots of chats sort of going on with lots of positive comments back to you that you may not have seen because you're talking, and a few questions that I've asked as we've gone along. One of the questions we had earlier was about, would you have any comments about young people having the flu jab?
That's a good question. Young people with ME having the flu jab, presumably.
Yes.
Some jabs are problematical. I think some of you have probably heard about HPV. And I'm basically, as an orthodox doctor, reasonably respectable, I approve of 90% of immunizations, and they are life-saving and fantastic. And if you've worked in Africa, you can see what people dying of tetanus are like. So 95% of jabs are worth having. And I do have doubts about the HPV, just because some patients are unlucky. And I have seen quite a few cases, but it's dangerous to mention it. But in general, with flu jabs, I would recommend having it because, as we all know, virus infections make ME worse. And in general, a flu jab can only give you, at worst, simulate a mild dose of flu. So it's better to have the jab than to have flu.
Thank you. That's very clear and very helpful. We did have a couple of requests as well for, have you got any recommendations of material that's aimed at young people themselves that helps to clarify, to help them understand the condition and how it affects young people? I can ask that of Debbie.
Yeah, I don't know.
Yeah, Debbie may well know the answer to some of that. And the other question was any resources. You don't necessarily have to do it now. We could do it afterwards, but for professionals involved in counselling, psychological therapies, really to help increase awareness. But I mean, there are plenty of resources around, but maybe Voices from the Shadows is a really helpful pointer.
Just for interest, there is talking of other resources, there's a movement called Physios for ME. 3 physios who've experienced it and their families, and they are a very valuable source of people who could talk to physios who are pushing the other approach, just like Tony Crouch of TYMES Trust as a social worker does marvelous work. We work as a kind of 2-man team going to case conferences, and he talks to social workers as of someone who understands ME, and we have both been invited to talk to principal social workers in Birmingham about this FII industry and how social workers should approach families with an open mind.
Okay, so maybe that's something for the future that we will certainly be keen to promote this as a YouTube video out to those involved in children and young people services in our region, in our area. Right. There's a query about a number of young people who catch ME often seem to be at around puberty age. Do you think hormones have any influence? Hormones obviously have masses of impact, but
yeah, I don't think that's the explanation.
Mm-hmm.
The best explanation I ever heard was from Betty Dowsett.
Mm-hmm.
And Betty Dowsett, it was a microbiologist and a virologist, and we all know that when you catch viruses, like chickenpox and mumps and measles, the younger you are, the better. And if you catch mumps when you're 25, or you catch chickenpox when you're 30, it's almost life-threatening. Okay? So for some reason, we were intended to catch viruses early. And enteroviruses, we usually would pick up through drinking dilute sewage.
Mm-hmm.
But for the last 100 years, we haven't been drinking sewage too much, although it's in plenty of our rivers. And the Dowsett hypothesis is that because we've not been exposed to enteroviruses in our childhood, and we then go and swim in sewage-infected waters in Greece and get a bad gut virus, that's when it really hits us badly. And I presented one of my cases in Bristol, and she was a surfer. And Anne McIntyre, the late Anne McIntyre, said, yes, she was a GP in the Southwest. Many of her patients were surfers. So I think it's more that teenagers get exposed to enteroviruses that they've never met before. And Betty Dowsett claimed that there was actually a world epidemic of Coxsackie bee in the 1980s. And I think there must have been a cluster in Durham because I saw so many new cases. So that's one hypothesis anyway. And the latest brilliant guy is Byron Hyde, who's just brought out 2 books on enteroviruses and ME. Mm-hmm. And he calls it the new polio. Sorry, that's my... No.
Mm.
Okay.
And obviously the big question that always comes up is particularly thinking of young people here, what is an appropriate treatment? Are we anywhere nearer to being able to actively help as opposed to waiting for recovery?
I'm attempting rather and failing to make a rearguard action for immunoglobulin.
Okay.
The boy who climbed those 3 mountains
mm-hmm.
was my first patient to receive it. I didn't give it to him. It was given to him by Dr. Irving Spur, the late GP from Weardale, and who worked with John Richardson, and he was a great protagonist for this. And ever since, I gave it to my 6 most severe cases in Durham, and they all made full recoveries. And my most severe case made the fullest recovery. And the CMO's report did a literature search in 2000, and they found that there were randomized controlled trials supporting immunoglobulin, and they actually concluded that they produced greater levels of improvement even than the famous CBT and KET. And yet that was whitewashed out of the report. And then the college's report whitewashed it out because of CJD, so you can't use blood products for this. And NICE guidelines blacklisted immunoglobulin in 2007 without any reason or any discussion. And I've since given it on advice to patients in Norway and Germany and 1 or 2 others, but I can't get anyone to prescribe it in this country. And my hunch is the earlier you give it, the better. Because I lost faith in it because of all the adult patients who were getting it from Dr. Spur and Richardson who didn't seem to be getting better.
Okay.
But some dramatic apparent responses.
Wow, amazing. And do you know what the rate of, you mentioned earlier about the rate of recovery for young people being significantly better than for adults? Do you know, do you have any statistics?
I wish I have 3 beautiful slides, okay. Which I can't show you.
We could send them on to people.
I'll send them to you. Yeah.
Lovely.
Basically, I followed 49 cases for 6 years, and a third of those made a full recovery in 2 to 6 years. 7 out of the 49 got worse, and the rest were up and down. So a third made a good recovery. Many of the middle group will have subsequently made a good recovery, and some were unlucky. And that, I think, is about as good as as good a picture as you can give.
Okay.
And that was with, I mean, the 6 severe ones had immunoglobulin, so it wasn't scientific, but basically a lot of them made spontaneous recoveries without immunoglobulin.
Okay. Do you have any advice about heart rate monitoring as part of pacing for children and young people with ME?
Not especially.
Right. Okay. That's a short
me another.
Yes, we can put that one to physios for me when we get to talk to them at some point in the future. And there was one more question, which was about any comments about the interaction with autism and ME, or dealing with young people who've got both ME and autism.
Wow. I personally don't think I've ever seen a case, so it's bad luck rather than a statistical association. Secondly, it's especially bad luck to have 2 such conditions. And thirdly, an autistic child may find it harder to be an ME patient than someone who is not autistic. So I think sympathy is in order. I should say that I sometimes find that adolescent boys are, non-autistic adolescent boys are particularly bad patients, whereas girls are very saintly and philosophical and have friends, and the boys are so disgruntled and so hate it that they don't like to talk about it and they prefer to deny it. But that's a generalization. Of course, more girls get it anyway. Okay, I better stop talking because it's Debbie's turn.
Yes, I'm gonna wind this bit up.
Shall I mute myself?
I think Eliane can be on top of that changeover. Can I just say a huge thank you to you? We do still have questions coming in, so I may come back to you. Are you able to stay for the next part of the session? Lovely, and hopefully we'll come back to you soon. You're muted, so you can just nod or wave. So thank you. Right. Okay, so I'm going to move the afternoon on and welcome Debbie Burgess from the TYMES Trust. I'm absolutely delighted that you're able to join us, Debbie. We were very keen to make sure people were fully aware of all the incredible work that the TYMES Trust does, and we're delighted to listen to a rundown of all the activities of the charity and your involvement with it. So think I'll let you do more of the introducing, if that's okay.
That's great, thank you.
And comments and everything welcome on the chat rooms.
Lovely.
Thanks
Thanks very much for inviting me.
Yeah,
As has been said, my name is Debbie and I'm the adviceline team director for the TYMES Trust, the Young ME Sufferers Trust. I've been asked to give an overview of our charity. I do have some slides which I'll put up in a minute. It just saves you all having to stare at my face for the next 5 or 10 minutes, which I don't think any of us are in the mood for today. But I'll try not to cause death by PowerPoint. So if you bear with me whilst I try and share my screen, I can get started. Here we go. Right, so as I say, I've been asked to give a little presentation on what we do at the TYMES Trust, but I thought it might be interesting for you all just to hear a little bit about me so that you can tell where I'm coming from. So I started volunteering for the TYMES Trust in 2009 and became their coordinator, then a director. I have a son with ME. He fell ill just before his 3rd birthday following chickenpox. It may have been something else, but that's what we remember. Unfortunately, we wouldn't get a diagnosis for another 3 years at that point. So he fell ill at 3 and didn't get a diagnosis till he was 6. And the reason we were given for that, going back to what Nigel said earlier, is that at the time, medical professionals were adamant that children that young couldn't get it. So I think they were hoping to wait and he would get better, or to wait and then give them a diagnosis at some point or other. I remember feeling at the time we got the diagnosis, fantastic, we're going to get the support that we need now. But I think from that point on, it was very hit and miss. And we decided at some point that the best thing for us as a family was to allow Ben to rest and recuperate and just take his time getting better. He was never able to go to school. He never has been able to go to school. He's 17 now. We know that, I think we tried all the things that you get offered, things that we hoped would help, and we watched him get worse when we tried certain things and so on and so forth. But he's 17 now, as I say, and he is feeling much better. We know that because he's a teenager and he wants very little to do with us now, opposed to needing us with him at all points in time over the last couple of years. So we're a little bit glad about that. To talk more about the TYMES Trust, sorry if I can't get my slides to work. Bear with me, there we go. To talk about the TYMES Trust, we're the longest running national support organisation for children and young people with ME. We also support families and any professionals that are involved in their care. In 1989, 2 young people with ME published the first TYMES magazine to give children with ME a voice, and that was the first time there was a place for them to share experiences and needs. TYMES Trust subsequently became a charity, a registered charity, and now offers a range of services, with the adviceline being the most prominent service. In 2010, we received the Queen's Award for Voluntary Service, which is like the MBE for volunteer groups, for pursuing the educational rights and advancing the care of young ME sufferers. Now, we don't receive any government funding and we don't employ fundraisers or marketing staff. Not to say that that's wrong, it's just that we're a small charity, but that allows us to concentrate on doing what we do best. What we offer, as a small charity, we're a membership organisation and we offer a range of different things. So our advice line is a free service, other than any calling charges. It's available 24/7 for you to leave a message and one of our advisors will call you back. We also have a TYMES Trust card, which might be of use for people with children at school or college. And the Trust card is a pass card that carries the child's photo and is signed by the head teacher. It's sort of an agreement between the family and the school that the child can just get assistance whilst they're on school premises, and it can be used for lots of different things. So if your child's at school or college, they might meet teachers who don't understand ME. So it can really make sense to try and protect them against that. And having the Trust card means that at a time when they need some assistance, the child may not feel like actually asking for it or have the energy to ask for the assistance they need. But the card is a pre-agreement saying, if I show you this card, I need to go to a restroom, or I need to lie down, or I need to go home, or, all of those things, or I can't do PE, which of course they probably shouldn't be doing anyway, but it can be quite useful to have that Trust card on their person. There's a number of things that it can be used for, and basically the most important one is that they can quietly ask for some help. I'm sure that we all know what children are like. They want to do the right thing. They also don't want to single themselves out as being somebody who's ill or needs extra support. So just by having the card on their desk or whatever, it can be a sign to the teacher that they need some support. So, you know, can the teacher give them some attention? Things like being allowed to wear dark glasses against the light, or to sit out from a lesson, have a snack in the classroom, and things like that. That can all be agreed beforehand, and when they have that card on their desk, that shows that they need the support, so they don't have to ask for it. We can send out the application form by post or email, so if anybody's interested in that, then please let us know. The other thing we offer are free awareness sessions for schools and other professionals. We've been to many schools across the UK giving face-to-face awareness sessions to their teachers. We can also deliver them via Zoom, and we're also very happy just to talk to other schools or any professionals that are involved with children with ME. And in the sessions, we discuss ME, how it can present in children, explain what it isn't, such as school refusal, and discuss with them the importance of talking to the family and offering an education that's right for the child. We have had some really positive feedback from the sessions, so if please bear them in mind if you're having any problems with schools or colleges. The member services we have, if I start with membership first of all, so you can join the trust. You don't have to join the trust to access any of the things under free services, but you can join. If you join, it's £10 per annum for anyone who's 26 plus, and it's a £10 one-off fee for anyone up to 26 years old. You can also join as what we call a joint membership. So essentially what that means is you can join as a parent and also have your child's details recorded. So, for example, the parent will receive a lot of all the mailings that we send out, and the children will receive free gifts and birthday cards, Christmas cards, if that's appropriate for them, and things like that. The other service we have is a professionals referral service, and what that means is we have a team of professionals who are psychiatrists, paediatricians, welfare rights advisors, educational psychologists, and of course Jane Colby, our very own chief exec. She is an ex-head teacher. We have a social services manager, Tony Crouch, which Nigel mentioned, and of course our paediatrician is Nigel. And they're there for families and other professionals to speak with. So you can contact us if you're in need of talking to other professionals like that, or you have involvement from social services and they would like to speak to somebody who knows about ME. We can put them in touch with our social services person. If you have a GP who doesn't know anything about ME and they'd like to speak to somebody who does, Nigel has spoken to many and educated them on ME and how to manage. So it's worthwhile just bearing things like that in mind. In terms of the advice line team, I think it's important to note that we are all volunteers. We all work pro bono for the trust. It's a small, very dedicated team, and our team will try to work to ensure we make contact with you at the right time. So if you leave a message for us, it can help to let us know when you're free for us to call you back. We're an experienced team. We're used to dealing with all the different types of challenges that people can have when they have children with ME. I think sometimes I worry that I make it sound very negative, but if you can just understand that we do not really take calls where people are saying, oh, I'm just calling you up to tell you that my school is magnificent and has given us everything we could possibly want, or that my doctor is fantastic. We get the calls where people need help because they're having problems with medical or education or social services. So we are slightly biased in our experience. We have many different situations that we work with people for, but things like, how can I get a diagnosis for my child? How can I refuse the treatment they're offering me? How can I get the education that my child needs? And why are social services involved with our family? All of those types of questions and more. And I think that one of the real benefits of our advice line is that everybody volunteering on the line has a child with ME themselves. So we've all had similar but also very different experiences. We've all educated in different ways. We've all used different ways of trying to make our child better. Some of our children have been home educated, some have gone to school, some have had tutors at home, others have gone to university. And I think with our experience and training and the knowledge on ME, it helps in our conversations with parents of children with ME. So Our main aim is to inform and empower families so that they have the correct information going forward and that they can deal with all of the different things that come up. We're not pushing any agenda or telling you what to do, but we do want to make sure you have the information you need when you need it. Talking about ME in children, I know Nigel has touched on this much better than this slide can ever do, but I thought it might be helpful to just briefly look at this. The reason that I bring this up is because we get a lot of calls where somebody will say to us, I know this sounds strange, I can't quite describe what he's going through, or is this weird? Am I the only person who's telling you this? And I can almost guarantee that you're not. In the context of ME, this is all normal. And I think that's one of the things that parents of children with ME really appreciate hearing. It doesn't necessarily make it better, but they know that they're not being judged or disbelieved, that these are the things that happen. So to look at them very briefly, with sudden exhaustion, a child just may need to lie down in a quiet place, and that can be quite difficult at school if that hasn't already been organised. Often this child will say they're tired an hour after they should really have stopped, if not more, because children want to do the thing that they've been asked to do. So it's worth listening to that. They can find it hard to concentrate. It can be too much of an effort, and the consequences on their energy levels can be quite severe. It may also cause headaches and sickness if they have to concentrate or do too much. The generalised pain and weakness can be really hard for parents to have to watch, really, because they can't walk long distances. Often painkillers won't have any effect. They'll often have pain in their joints and their limbs. They have difficulty with recall and difficulty in understanding new information. And that can make it very hard to educate a child with ME, because they will have forgotten something that they were taught 5 minutes before. And there are times for a child with ME that they simply cannot be in education. It may be that at the beginning, or when it's caught, or for however long, they may just need to take some time out to rest and recuperate. If they don't have to, then that's fantastic. But be aware that there can be that phase in the illness, I think. The reversal of sleep rhythms is very difficult for families. We have a number, particularly at what we call the beginning of the illness. And it happened with my own son. So children will be awake at night and then sleepy all day. And that can make doing anything normal, and I'm using quote marks here, very difficult. I know Nigel has worked on this in the past, and he might be able to shed more light on it afterwards, but it's a very, very usual symptom of childhood paediatric ME. Also, emotional liability. As you can imagine, if a child has led up till that point a fairly normal life, to suddenly have ME is a massive blow to them. If they're not able to see their friends, if they're being pressured by school, and simply people just not understanding them, it can cause enormous distress, rage. They're just upset by all of these things. So I think it's. I remember my son when he was younger, running around in circles and everyone telling me how great he looked and he was obviously so much better, when in fact we could see that he was running on adrenaline and was about to have a massive crash that would take months to recover from. So I think as a family you begin to pick up on all of these points, and it's worth believing yourself. Trust your own instincts where these things are concerned. If you're seeing it, then it's true. And so very quickly, impaired blood sugar. So often children with ME will need to have snacks during the day. It's a good thing to put in place at school so that they can eat at their desk if they need to. Impaired abnormal response to exercise. All of us know that the hallmark symptom of ME is post-exertional malaise or relapse, and it applies just as much to children with ME. The key point here, I think, is not to think of it as just due to physical exercise. It can be education, cognitive, emotional, any of those things where the child has outlaid energy can cause this crash up to 72 hours later. And I know that there were lots of times in my own son's illness where we thought, I actually don't know why this crash has happened. And then we think, oh, well, actually, he got very excited about something the other day, or he got very upset about something the other day. And that, at that point in time, was enough to cause this post-exertional relapse. And I want to just mention two things that came up in questions to Nigel. We talked about puberty, and I would say that we have had lots of calls from parents who say their child has gotten so much worse when puberty hit. I haven't got the answers for that, but I think there's definitely something for us to look into. All of the parents we spoke to have said there have been no change in their child's routine. There's been no change in illness. They haven't picked up any new illnesses, but simply hitting puberty for the next couple of years has made their child so much worse. And actually it happened with my own son. The other thing I wanted to mention is that we also hear from a high number of callers whose children have autism as well, or they have a family where other children have autism. I'm not making a link between the two. We don't have any statistics on that as yet, but we do get significant numbers of callers where children will have autism as well, or there are other children in the family who have it. So that's quite an interesting point. I think it may be worth looking into. A significant number of the calls we take are related to education, and if we look at the numbers on this slide, they are quite old. They're not new, but they are significant, and you'll see that ME is very, very prevalent in schools. If we're looking at ME is the biggest cause of long-term sickness absence in schools. So a study of just over 300,000 pupils revealed that 51% of those on long-term sick leave had ME. So it's the biggest category of pupil with medical needs requiring support. The other thing to mention here is that a lot of parents of children with ME will be told that their children do not have what's called special educational needs, and that's nonsense. Special educational needs are basically something for which a school can support you. And if you're told just without any consultation, well, your child doesn't have SEN or special educational needs, so we can't give you these things, that is complete nonsense. And we can help you with that if you want to talk with us or other charities that are out there, but it is worth bearing in mind. Many schools are brilliant with children with ME, and many schools aren't. But for most of the schools, the majority of the schools, they really struggle with the intermittent absence that having ME can cause for a child. Schools struggle recording absence anyway, and it's a conversation that we're currently having with the Department for Education to try and figure out, how do we fix this? How can we say to schools, look, here is how you record the absence of a child with a long-term health condition. Here is how, as a family, you can speak to the school or college and have them record your child's absence so that you're not being threatened with school attendance orders or fines or any of those things. It's an ongoing conversation, but I did want people to know that that's what we're trying to achieve. That's what we're trying to do at the moment. It's for all families caring for children with ME, it's worthwhile to remember that by law, your child is entitled to what's called a suitable education. And basically what that means is that if a child is ill, they should be offered education in a manner that works best for them. I'm not saying it's as easy as that. I'm not saying you can just call the school and say, well, we want all of these things. It's a conversation with the school, and it's knowing your rights. And again, we can help you with that if needs be. There are lots of different ways a child can be educated. That's perfectly reasonable. And that includes things like home tuition, the school sending work home, online education, or indeed a break from education if that's needed at any point. It's the law, but you may need to ask for it. With education being a key focus on our advice line, some of the key points really are: the most appropriate thing for a child is to have what's called a sort of an energy efficient education. So whatever works for them, whether it's home tuition, staying at home, having online education, or any of the things that can be offered. But pushing an ill child will not make them recover any quicker. They don't need motivation. They simply need to be allowed time to recover. If they do, but they need rest and recuperation, most importantly. I mentioned social contact in the second paragraph here because often parents and the professionals working with them are concerned about children remaining in touch with their friends, rightly so. But I think it's something we all have to accept, that at some point in the illness, if the child is ill enough, they may actually not be able to have contact with anybody, and what they need is to be allowed to rest, recuperate, if that helps, and then come back into, you know, their social contact with other people. Even if a child isn't at school, it's still we're all still capable of doing all the work in the background so that they still maintain contact with their friends. You know, maybe a telephone conversation that's organised by the parents for them one day, a Zoom meet with their friends another day. But all of these things can be organised. They don't have to go to school, for example, to have social contact. They won't be desocialised because they're too ill to go to school. And then finally, there's enough law and guidance to request and receive the right type of education for an ill child. Again, we can help you with this if you're finding it a struggle. It isn't always as simple as just saying, my child needs this, please give it to me. It can be a series of conversations, a series of arguments for some people, but it's definitely worth committing to getting it, because it can be the difference between the child feeling worse and the child getting better. And then we're nearly done, don't worry, not too many more slides. This information is from the report from the Chief Medical Officer's Working Group, which Nigel mentioned earlier. And what it says is that nearly all children will require the provision of home tuition and or distance learning. And that's is obviously in relation to children with ME. And that specifically a young person should never be forced to study. It will not make them better. You can't force this child to get better. And I think, unfortunately, in the worst cases we come across, teachers feel, because they're given the wrong medical advice often, but they feel, due to a number of different reasons, and absence recording is definitely one, but they feel that if they just push and bully, that child will just simply get better and do it. And of course, that isn't the case. And then finally, there are some more severely disabled children who actually may need much longer term home education. And I think with any of these cases, it is better for a parent to plan for the longer term. A number of the calls that we get talk about, as a parent, you've promised the school that if they'll give your child a flexible timetable or allow them to come in twice a week, they'll be back and doing a full week next term. And I think that's possibly the worst thing that you can do. I think it's always better for everybody concerned to look at the long term. And if things get better before that, fantastic. Let the child go to school or college or whatever it is they want to do. But to plan for weeks is not going to help anybody. It's much better to plan for the entire terms or years or whatever. Now, so again, what we say, the general points we would make on supporting and educating a child are listed here, and I'll run through them briefly. These have been helpful at times when talking to schools and colleges about our children and how best to support them. So very simple, listen to the child, stop when they need to stop. We talked earlier about how to, trying to make them go a little further, or can you just go for another 5 minutes, or just run around the block there, or ride your bike for an hour. All of those things, none of them will help the child. It will just result in relapses and extended absences from their friends and their family. Education does not equal school. There's absolutely nothing wrong with going to school, but you don't have to, and it's perfectly legal to home educate your child, and by that I mean deregister. I'm not pushing either or, but if your child is not doing well at school, then of course there are many things that can be put in place with the school itself to try and rectify that. But you can also take them out of school for a while so that they're not registered at all. Again, that's a big conversation for a family, but we can help you with that. In a TYMES Trust study of the 330,000 children we saw on the previous slide, only 1 in 25 could attend school full time. So hopefully you can see that it is a huge issue for children trying to go to school. The most important thing really is allowing them to do it at their own pace and allowing them to stop when they need to. Now, understanding that the illness can vary throughout the day is quite important, because for some children they'll feel better in the morning and some in the afternoon, and then without you having any idea of what's happened, it will suddenly change, and suddenly they're better in the afternoon and they're not better in the morning. So it's that flexibility that if we can offer it, that's key for the children. It isn't just fatigue, it's the cognitive impairment and the chronic pain that is such a huge burden for the children that we have and that we speak to. Their bodies are processing so much more before they attempt to learn. It's not surprising that they can't do it for too long. And the fatigue is both physical and mental. So I think it's really key to remember that as well, and to relay that to others who are who are, working with the child. And we recognise as well that you'll hear conflicting opinions on the illness, but there is robust evidence to show that this is a physical, biological process. It's not a psychological issue that starts it, but there's no harm in getting some psychological support if you've been ill for any length of time. And then, of course, children need to rest, whether that's at home or at school. It's just a fact that children will need to rest when they're out and about. And we've talked briefly about relapses can be brought on by any overload, not just physical exercise. It's really key to remember that it can be emotional or cognitive. And the key part here really is that ME can have a substantial and long-term adverse effect on normal day-to-day activities, and is therefore recognised as a disability under the Equality Act 2010. Now, if you have a disability, and there are some conditions that are automatically a disability, but others aren't. So you have to prove to a certain extent that it has this effect on you. But the Equality Act states that schools and higher education institutions have a duty to make reasonable adjustments, and all reasonable adjustments are simply just reducing or removing barriers to education or access to any of the services or facilities that children might need access to. And it can be something very, very simple, things like starting later at school, having a place to rest during the day, using the lifts where available, and so on. The reason I mention it is because some schools, bizarrely, will ignore the education law and guidance. But when you talk to them about disability law and guidance, they're slightly more awake. So I think it's worth mentioning both if you ever have any problems with schools and getting your children the right education they need. And then finally, I remember speaking with our educational psychologist, who's a wonderful woman, and she suggested that if the child can only study one subject, which does happen quite frequently, let them study their favourite subject, because this really boosts their self-esteem and can help them enjoy their learning. And we've had so many children tell us, I feel like I'm being set up to fail. They're telling me I have to do 3 subjects, I have to do this, I have to do that. And I know I can't do it, but yet I'm still expected to try, and I know it will make me worse. I think if they're already going through this horrific illness, then the least we can do is try and, if we can continue with their learning, the least we can do is let them study something that they like and enjoy. And I think this rings very true for me. I think essentially children with ME do not lack motivation. They are simply too ill to achieve what a well person can. And I think just keep repeating that to everybody that doesn't believe you, because it's true. And then finally, we have a document on our website called Explain Your Abilities. And as you can see, it was created by Jane Colby and our educational psychologist. Now, it's a document that helps children explain what they can and can't do. And it can be very useful for anybody, really. The key part of this really is that you don't want children to make themselves ill filling it out. So they can just do it in short, bite-sized pieces. The idea is for them to take time to think about questions that are in the document, such as, how long do you think you could do this? You can do this for how long? Can you do all of these other things? And they can answer honestly. And of course, things change over time, so they may want to fill it out again later on. They can get parents to help, or they simply don't have to do it at all. But it helps them, if it helps them to write down what they can manage and to show other people this document, it can be really useful for them. And also what we found over the years is that for some children who are finding it hard to accept their illness, this can be really helpful for them to sit down and think about, what is it that I'm able to do now? And it doesn't mean that they've given up. It simply means that they're having to take this attitude for this specific length of time. And if they've got any problems with the questions on it, they can always give us a call, or we can talk them through it. And that's it. That's all of my slides. So thank you very much for listening, and I'll take this down now.
Wow, that was absolutely amazing, Debbie. Thank you so much. You've covered
you're very welcome.
so much there. And also, I just wanted to add a kind of personal thank you, because when my daughter was severely ill, through the TYMES Trust, she received cards which kind of arrived through the post from nowhere, even sort of semi-anonymous little kind of presents, craft things, and letters. And what was so crucial is that being in touch with your friends when you're young, you know, means you might get a Facebook message, you might get, you know, WhatsApp or text or whatever, and there's an expectation to reply. Whereas the nice thing about the TYMES Trust is that she was too ill to reply. So it's one way, and it was so much appreciated. And certainly lots of things that you've said about motivation. You know, young people with ME are not demotivated. They are desperate to do stuff. And how important it is, as you say, just to take all the pressure off, to give their body and everything the chance to do its very best to heal and recover. So taking all the pressure off, including, for my daughter, she had periods of time where she was doing no schooling, absolutely no schooling whatsoever. So yes, all that adaptation, but sometimes you need to do none of it. Just
I think you're absolutely right.
Yeah.
Sometimes you have to. I think as well, what I would like to say to everybody, and who am I, but I think is go easy on yourself, because I think at some points, and we talk about this as an adviceline team, but I think at some point you will have done something or thought something that was incorrect about the condition. You'll think, well, you know, can she not actually just get up and do a little bit of something? It's natural. It's where your thoughts go, because we're used to following this pathway of, you know, school, college, university, whatever it is. And there's nothing wrong with that. Just forgive yourself and move on, because we're all learning every single day when we have children with ME. I'm certainly not perfect. Thankfully, I won't allow my son on this, because he'd tell you that I'm certainly not perfect and I've made mistakes. But it does happen. We all make mistakes, and I think it's just listening to the child, because what they're telling you is truthful and honest.
And we're used to being in the role, aren't we, of kind of adults know best. And so I've learnt not to argue.
Absolutely, which is very hard with a teenager, to be honest with you sometimes. But it's I agree with you. I think you have to just let them stop.
There's been quite a lot of chat here, which is it's lovely. People have raised questions, and then so Naomi, Burgess and others have kindly answered them for us. So that's really nice.
I didn't realise Naomi was on here.
So questions about, so one of the things that's not been answered is TYMES Trust UK only? That there are people on this call from Cork and South of Ireland, and can they access your support?
They absolutely can. In terms of everything that we've got on our website is free to use, as long as it's not amended, and they can use anything on our website. We have spoken to people who are in different countries, or you know, people in ERA as well as Northern Ireland, and whilst we're not experts on sort of like the education law, we will do our best to support them. But what they can also do is, as I say, is just use whatever is on our website as well, if they want to take that and give it out to people.
Lovely, thank you. And so there's been various questions about sort of what age support around education. Does it continue after 19? And I think the answer is kind of, you can get that support that you need until the age of 25.
That's with an EHCP. That's
yes,
right, yeah. And
that can be useful. That can be helpful at university as well.
You can't get an EHCP if you go to university,
right?
Yeah,
okay.
But you can get. Is it disabled students allowance? We're just about to put on our website actually a document on going to, if I can see, a document on going to university and what you can, sort of somebody's story, but also information on what you can request for support. And we do have a family whose child went to university who's willing to speak to other families as well, so that can be quite useful.
Okay, that's brilliant. Nigel, did you want to come in there?
Yeah, could I make it? I thought of a few things listening to Debbie's excellent presentation. Just I wanted to add them. They're not really related to questions, but just in case they're helpful. And I've got a train to catch, so maybe I could say them and go.
Okay.
Is there any other questions for me? The first is I saw that chat, one of the chats saying how they were referred to UCLH and what a terrible experience it was. And there is a tendency for for doctors to just say, you must go to such and such a place. Now, referring you somewhere is a form of management. If a surgeon takes your leg off, he has to get you to sign informed consent. And what I'd like to recommend is to use the concept of informed consent. Sometimes you just say, oh, you're going to go to London. No, you're going to Bath. You've got to see a specialist. No, you can recommend it. We can debate the pros and cons, and I can decide. So withholding informed consent is a useful term. Another one is this repetitive pressure that Debbie referred to of teachers setting people targets and coaxing and doing this and doing that. And a good term to use there is you're interfering with medical management. How much exercise you demand of a child is medical management, and it's not for a non-medical person to interfere with it. So, and that should, I mean, if you've got a protective pediatrician, that should work. But talking of protective pediatricians, I'm always reminded of the story of a girl who had recovered to 90%. She was symptom-free, at school, full-time, sleeping, everything fine. But her pediatrician very sensibly said, as she was recovering, she should still be off sport. But she used to be good at athletics. And the teachers went against medical advice and coaxed her into a cross-country run, after which she had an 18-month relapse off school. So having ME mildly is still a danger. I always tell my patients to avoid getting shipwrecked on the Titanic. I would say that it's useful to use percentages. It's a very rough and ready subjective thing. 100% is climbing mountains every day for a fortnight. 5% is bedridden in severe pain. 0% is dead. But I put in all my reports that such and such a person is functioning at 30% of full capacity or 40%. And you have to be 70% full capacity to attend school off sport. So percentages are useful and helpful. And one other marker, which is not in hardly in any of the definitions or guidelines as a symptom, and that is undue susceptibility to viruses. Now, we know ME is triggered by a virus, but we all know that children get worse each time they get a virus. But it's possible not to be diagnosed and to still have that clue. And I had a boy who was, for 3 years, every time he caught a cold, he was off school for a month. And when he didn't have a cold, he was fine attending school full time. Because he didn't know he had ME, he went backpacking with his father in Scotland, carrying his tent. And that exertion produced a relapse, brought him down to 30%, and he was quite ill for several years. So being able to warn the mild cases in the 80 to 90% is important. Good, I think that's all. If there's any last question for me, I'm happy to answer it. Otherwise, I'm running away because I've got a Zoom session with Debbie tomorrow morning. Debbie,
I do have one last question for you, which is...
Just before you do, Debbie, is it 11 o'clock or 12 o'clock?
She's on mute. It's 12.
12. My email says 11 and my diary says 12. It's 12. Speak on the phone.
Yeah, I'll call you later.
It's 12.
Yeah.
Thank you.
12.
Call me later.
I'll call you later. Okay.
And one last question from Caroline.
Thank you. We're obviously in the time where COVID is on the scene, and I wondered where we can't kind of spend the rest of the afternoon without one mention of it. Yes. We're kind of 6 months on when many people caught COVID in the early part of the year. Do you anticipate, or have you any comment really about young people struggling with recovery from COVID?
I haven't personally seen any new cases of ME following COVID, but I'm sure they're happening. It's almost good for the movement that a lot of people are now discovering the reality of ME. I'm sure that even people with mild ME deserve shielding, because I would hate them to have a severe dose of COVID on top of their ME. And I'm advising a lot of families not to send their kids to school, whatever the doctor says, whatever the government says. So it's just common sense that a bad dose of COVID is not good for someone with ME. So that's it. Good. Can I say thank you and happy Christmas to all our listeners?
Thank you. And yeah, you'll no doubt do the dance as you leave. Thank you. Hugely appreciate your time. Thank you. And for sharing all the knowledge and expertise. And yeah, we will be in touch and hopefully pass on suggestions of resources to all the people who've been following us today. So massive thank you.
Best
Dr.
wishes
Speight.
to all. Best wishes to all. A pleasure meeting you. Cheers.
Bye, Nigel.
Thank you, Nigel. So if there are any further questions for TYMES Trust, there's a whole long list of thank yous to you, Debbie. So in the chat thing. So that's really nice. Are there any final questions to go to the TYMES Trust that I've not covered? So. There's one about puberty, which we didn't manage to ask Dr. Speight, so maybe we can do that another way. So I'd just like to say a massive thank you to you for contributing today. That was a very thorough run through, and really appreciated that. Massively appreciate all the work you do. And thank you to everybody who's joined us this afternoon. Particular thanks to Eliane, who's helped us with all the technology, and thanks to Carol Binks, who's one of our members who helped set up the talk with Dr. Speight for us. So that's absolutely brilliant. So for anybody who's in and around Sheffield, South Yorkshire, North Derbyshire, please hop on to our website, www.sheffieldmegroup.co.uk. You can join in our Oktoberfest activities, which was lots and lots of fun because people have been so isolated for so long. And our next talk, which will be the 22nd of October, will be by Professor Mark Van Ness, who's head of the Workwell Foundation in California, and he's going to be delivering a program about pacing and exercise. So he has a lot of very detailed research which looks at the impact of aerobic and anaerobic exercise on post-exertional malaise, relevant to people with fibromyalgia as well as people with ME. So please join us on the 22nd. You'll see notices about that on our Facebook pages, our Facebook group, and our website. So I'm just going to check the last few messages, which go thank you, and lovely. And oh, great, someone's moving to Sheffield. Yeah, we like that. Thank you. So, okay. So thank you very much to everybody for joining us this afternoon, and look forward to having a cup of tea. So, all right. Cheers. Bye then.